My most terrifying case is a medical student, the patient who walked into the ER alone but never existed. I'm writing this because I need someone to know what happened. Not for sympathy, not for validation, but because what I experienced during my final year clinical rotation contradicts everything I was taught about documentation, protocol, and objective reality in medicine. My name is irrelevant. What matters is that I was a fourth-year medical student at a Level 1 trauma center in the Midwest, 3 months from graduation. By that point, I completed rotations in internal medicine, surgery, pediatrics, and psychiatry. I pronounced deaths. I performed chest compressions until my arms went numb. I'd restrained patients in acute psychosis and sedated them according to protocol. I'd seen decomposed bodies brought in by EMS and patients who coded on the table despite our best efforts. I thought I understood the limits of what medicine could show me. I thought I'd seen everything that could shake a person in this profession. Traumatic deaths, pediatric codes, violent psych patients, the mundane horror of end-stage disease. I'd held the hand of a woman as she died from septic shock, her family screaming in the hallway. I'd watched a surgical resident's hand slip during an emergency thoracotomy, blood spraying across the trauma bay. I'd sat with a 6-year-old in the ICU who would never wake up after a car accident. None of it prepared me for what I'm about to tell you. I was wrong about understanding the limits. Medicine doesn't just show you death. Sometimes it shows you something worse. The spaces between life and death where our systems of documentation and proof break down entirely. The night shift. It was a Tuesday in late October. The kind of night where autumn has fully settled into the Midwest. Cold, crisp, the air carrying the smell of dead leaves and rain. I was assigned to the night shift in the emergency department, 11 p.m. to 7 a.m. By that point in my rotation, I'd done 7 consecutive nights. My circadian rhythm was completely inverted. I slept during the day with blackout curtains and white noise, and I came alive under fluorescent lights. The attending physician was Dr. Reyes, a sharp, no-nonsense EM doc with 15 years of experience. She'd worked in Level 1 trauma centers in Detroit and Philadelphia before settling at our hospital. She'd seen gunshot wounds, mass casualty incidents, and every imaginable presentation of human suffering. She was the kind of physician who could run a code while simultaneously teaching, her voice calm and measured even as someone's chest cracked under compressions. The nursing staff that night was solid. Jamie had been an ER nurse for 12 years. Marcus was newer but competent, former Army medic. And there was Linda, the charge nurse, who ran the department like a general commanding troops. They moved through traumas with choreographed precision, anticipating orders before they were given. The shift started busy, as they always did. A car accident came in at 11:30. 2 patients, minor injuries, discharged by 1 a.m. We had the usual parade. A kidney stone, 2 lacerations requiring sutures, a fall from standing height in an elderly woman, chest pain that turned out to be gastroesophageal reflux, a young man with testicular torsion who needed emergency surgery. We had a psych patient in 4-point restraints after a suicide attempt, waiting for the crisis team. By 2:30 a.m., the ER had quieted. We'd cleared the waiting room. The monitors in occupied rooms beat their steady rhythms. The overhead fluorescents buzzed faintly in the hallway, that particular frequency that seems to exist only in hospitals after midnight. The air smelled like antiseptic and recycled ventilation, with an underlying note of something organic and slightly unpleasant, the smell of sick people in close quarters. Dr. Reyes told me to monitor the observation bay. 3 beds separated by curtains, reserved for patients requiring short-term evaluation before admission or discharge. 2 beds were empty. The third held Mr. Patterson, a 72-year-old who'd had a syncopal episode at home. He was sleeping soundly, vitals stable, waiting for his cardiac enzymes to come back. I sat at the rolling workstation outside the bay, entering notes into the electronic medical record. The EMR system was called Epic, like most hospitals used. I'd become proficient at navigating its labyrinthine menus and documentation requirements. The hallway stretched long and dim toward radiology. Security made their rounds every 20 minutes. I could hear their radios crackling as they passed. Everything was routine. Everything was normal. Then I heard the curtain slide open behind me. I turned. A man stood just inside the observation bay, at the entrance nearest the hallway. He was in his late 40s, maybe early 50s. Average height, maybe 5'10". Pale complexion, the kind of pale that suggested he didn't spend much time outdoors. He was wearing a wrinkled button-down shirt, light blue, and dark slacks. His hair was neat but slightly disheveled, like he'd been lying down. He wasn't bleeding. He wasn't clutching his chest. He wasn't in obvious distress. But something about him immediately struck me as wrong. Not wrong in a medical sense. Wrong in a way I couldn't articulate. He was too still, too calm. The kind of calm you see in people who are in shock, but don't know it yet. "Excuse me," he said quietly. His voice was soft, almost apologetic. "I'm not feeling well." I stood immediately, noting the time on my watch, 2:47 a.m. Standard protocol. Always note the time. I guided him to the empty middle bed, observation bay 2, and pulled the curtain for privacy. "What brought you in tonight?" I asked, pulling on gloves from the wall dispenser. "Chest discomfort," he said. His voice was calm, measured. "It started about an hour ago. Just pressure, like someone sitting on my chest. And I've been feeling dizzy." Classic presentation. Possible acute coronary syndrome, ACS. The kind of presentation that makes every medical professional immediately alert. Chest pressure. Diaphoresis. Shortness of breath. These are the words that get you fast-tracked through triage, that get you an ECG within 10 minutes, that get you aspirin and nitroglycerin and a cardiology consult. I began the initial assessment, running through the checklist I performed hundreds of times. "Any shortness of breath?" "A little," he said. "Nothing severe." "Nausea?" "Vomiting." "No." "Does the pain radiate anywhere?" "Jaw, arm, back." "No, just the chest." "Any history of heart problems?" "No." "Are you on any medications?" "No." I placed the pulse oximeter on his finger. The device was one of those newer models with a bright LED screen. It flickered for a moment, then displayed the reading. 88% oxygen saturation. Low. Not dangerously low, but concerning. Normal is 95% or above. Heart rate, 54 BPM. Bradycardic. Below 60 is generally considered slow. I reached for the blood pressure cuff. As I wrapped it around his arm, I noticed the skin. It was cold. Not cool cold. The kind of cold you feel on a body that's been in the morgue cooler. The kind of cold that makes you check the room temperature and wonder if the heating system is broken. "Have you been outside tonight?" I asked, trying to explain it away. "No," he said. "I've been home." The blood pressure cuff inflated with its characteristic whirring sound. The reading appeared, 102/64. Slightly low, but within acceptable range for someone his age. Not overtly hypotensive. I grabbed the stethoscope from around my neck and listened to his lungs. Clear bilaterally. No wheezes, no crackles, no evidence of fluid. I listened to his heart. Regular rhythm, no murmurs, no extra sounds. Textbook normal. I checked his pupils with my pen light. Equal, round, reactive to light and accommodation. I pressed on his abdomen. Soft, non-tender, no organomegaly. Everything was textbook. His physical exam didn't match the severity I was expecting from his symptoms. But that's the thing about cardiac events. They can present subtly. Silent MIs are called silent for a reason. "I'm going to get you on a monitor and run an ECG." I said, "Have you had chest pain before?" He paused, just for a moment. A hesitation, so brief I almost missed it. "Once," he said. "A long time ago." "Did you go to the hospital?" "Yes." "What did they tell you?" Another pause. "They said it was nothing serious." I made a mental note of that. History of chest pain. Previous ER visit. I'd need to pull those records. I wheeled the cardiac monitor to his bedside. It was a Philips model, standard in most ERs. I grabbed the electrode pads and placed them on his chest in the familiar pattern. Right upper chest, left upper chest, left lower chest, right lower chest. The monitor screen initialized, showing familiar tracing of electrical activity across his heart. The waveform appeared. Normal sinus rhythm. The P wave, QRS complex, T wave, all present, all appropriately spaced. Then it stuttered. For just 2 seconds, maybe less, the line went completely flat. Asystole. No electrical activity. No heartbeat. The kind of rhythm you see in dead people. I looked at the patient. He was sitting upright, breathing normally, eyes open, looking at me with that same calm expression. The monitor resumed. Normal sinus rhythm. Heart rate, 56 BPM. I felt a chill run down my spine, but I forced myself to think logically. Artifact. It had to be artifact. Loose lead, electrical interference from another machine, patient movement. It happens all the time. Monitors are sensitive. They pick up everything. Did you feel anything just now? I asked, keeping my voice casual. No, he said. Should I have? No. Just checking. I adjusted the leads, making sure they were firmly attached. The rhythm continued, steady and unremarkable. I ran the 12-lead ECG. The machine is a separate device, more sensitive than the basic monitor. It prints out a comprehensive view of the heart's electrical activity from 12 different angles. I pressed a button and the machine hummed, printing the results on thin thermal paper. I tore it off and reviewed it under the overhead light. The tracing was wrong. Not abnormal in a pathological sense. Wrong. The intervals were correct. PR interval, QRS duration, QT interval, all within normal limits. But the morphology was subtly distorted. The waveforms were slightly blurred, like a photocopy of a photocopy, like the machine had printed something that wasn't quite there. And the timestamp at the top read, October 19th, 2021. 3 years ago. I stared at it, checked the machine's display panel. The system clock showed the correct date, October 19th, 2024. I looked at the printed strip again. Is something wrong? The patient asked. No, I said quickly. Just let me run this again. I hit the button again. The machine hummed, printed a new strip. This time it was correct. October 19th, 2024. Normal sinus rhythm with nonspecific ST changes. Nothing concerning. Just the slight variations you see in most ECGs. I folded both strips and placed them in my pocket. I didn't know why. Instinct, maybe. The need to have physical evidence of what I'd seen. Everything looks okay, I said. I'm going to get your information into the system and have the attending physician come take a look. Thank you, he said quietly. I returned to the workstation and opened the patient registration system on the computer. This is standard intake procedure. Every patient who comes through the ER needs to be registered. Name, date of birth, address, insurance information, chief complaint, next of kin. The system generates a medical record number, prints a wristband, and creates a chart in Epic. I need some information for our records, I said, pulling up the intake form. What's your full name? He hesitated, just a fraction of a second. So brief I might have imagined it. Daniel Cormier, he said. I typed it into the search field. The system searches the entire hospital database, looking for existing patient records. If someone's been to our facility before, their information pops up automatically. The screen refreshed. No results found. That wasn't unusual. New patients came through all the time. Date of birth, March 8th, 1976. I entered it. 48 years old. I ran the search again with both name and DOB. Nothing. Have you been to this hospital before? Yes, he said. Once. Do you remember when? He paused. A few years ago. And they would have registered you then? I assume so. I tried a broader search. Sometimes names are misspelled. Sometimes dates are transposed. I searched for Daniel Cormier with various birth years. Nothing. I tried the statewide Health Information Exchange, a database that shares patient records across all hospitals in the state. Sometimes patients go to different facilities, and we need to access their history. No matches. What's your address, Mr. Cormier? He told me. I entered it into the system. No matches. Social Security number? Another pause. Longer this time. I don't remember it, he said. That was unusual. Most people know their Social Security number, or at least have a card with them. But it happens. People forget. People don't carry their wallets. That's okay, I said. Do you have your insurance card? I don't think I have it with me. Any ID? He patted his pockets. No, I'm sorry. This was getting frustrating, but not impossible. We treated unidentified patients all the time. Homeless people, trauma patients who came in unconscious, psychiatric patients who couldn't or wouldn't give information. You register them as John Doe with a unique identifier and sort out later. All right, I'm going to print you a wristband with what we have, I said. We can update the insurance information later. I input his data manually into the registration system. Daniel Cormier, DOB March 8, 1976, chief complaint, chest pain. I created a new patient record and sent it to the wristband printer at the nurse's station. I heard the printer hum briefly, then stop. No wristband emerged. I stood and walked to the nurse's station. Jamie was charting on a computer. The wristband printer sat on the counter, its error light blinking red. System timeout. I pressed the reset button. Tried again. Same error. Hey, Jamie, I said. The printer's not working. She looked up. Again? IT was supposed to fix that yesterday. Can you try from your terminal? Sure. She logged in, pulled up the registration system, and searched for Daniel Cormier. The screen showed patient record not found. Did you submit it? She asked. Yeah, I just created a record. She searched again. Nothing. That's weird, she muttered. She manually keyed in his information, name, birth date, chief complaint, and tried to create a new record. The system froze. The loading icon spun for 30 seconds, then returned an error. Database error. Unable to create record. What the hell? Jamie said. She tried again. Same error. Marcus walked over. What's going on? System's not cooperating. Jamie said. Won't create a patient record. Did you try restarting the terminal? Hold on. She logged out and logged back in. Tried again. Database error. I'll call IT, she said. Just document everything manually for now. We can get him in the system later. All right. I grabbed a paper chart, old school, the kind we barely use anymore, and started filling out by hand. Name, age, chief complaint, initial vitals. I returned to the observation bay. The patient was still sitting upright on the bed. The monitor beside him showed a steady rhythm. Oxygen saturation, 89%. Heart rate, 52 BPM. But when I looked at the leads on his chest, I noticed something strange. The adhesive pads were still in place, the white circular electrodes stuck to his skin, but the wires weren't taut. They hung loosely, with too much slack, as if no body was pulling against them, as if the electrodes were stuck to something that wasn't quite solid. I blinked, looked again. The wires looked normal. I was tired. I'd been up for too many nights in a row. Micro-sleeps, hallucinations, they happen to residents and medical students all the time. Sleep deprivation does strange things to perception. Mr. Cormier, I'm going to get the attending physician, I said. She'll want to examine you herself. Just sit tight, okay? Of course, he said softly. Take your time. I walked quickly down the hallway to the physician workroom. A small office where the attending and residents reviewed imaging, made phone calls, and caught brief moments of rest between patients. Dr. Reyes was sitting at the desk, reviewing a CT scan on the large monitor mounted to the wall. Dr. Reyes, I said, I have a patient in observation too. Middle-aged male, presenting with chest pressure and dizziness. Vitals are concerning: bradycardia, hypoxia, borderline hypotension. ECG shows nonspecific changes. But here's the thing, I can't get him into the system. She turned to look at me. Can't get him in? Registration won't pull up any existing record. When I try to create a new one, it errors out. Wristband printer won't work. It's like the system won't recognize that he exists. She frowned. Did you try different terminals? Yeah, Jamie tried too. Same problem. Did he give you a name? Daniel Cormier. Says he's been here before a few years ago, but there's no record. No ID. No. Says he doesn't have it with him. Dr. Reyes stood. All right, let me finish reviewing the scan, and I'll be right there. In the meantime, get a chest x-ray, CBC, CMP, troponin. If we can't get him in the system, we'll register him as a John Doe and sort out later. Got it. I returned to the observation bay, mentally running through the orders. Chest x-ray to rule out any pulmonary pathology. Complete blood count to check for anemia or infection. Comprehensive metabolic panel to assess kidney function and electrolytes. Troponin to check for cardiac injury. The curtain was open. The bed was empty. I stopped, staring. The sheets were smooth, undisturbed, tucked in at the corners the way housekeeping leaves them. The monitor was off, not just displaying a flat line, but completely powered down, dark screen, no lights. The leads lay coiled neatly on the side table, the electrode pad still attached to the wires. I stepped inside, looked around, checked behind the curtain, checked the adjoining bathroom. Nothing. The patient was gone. Jamie, I called. She appeared at the entrance to the bay. Yeah. Did you see my patient leave? She looked confused. What patient? Observation 2. The guy I was just working up. Did he walk out? She looked past me at the empty bed. I've been at the station the whole time. No one came through. He was just here, literally 2 minutes ago. Maybe he went to the bathroom in the main hallway. I jogged down the corridor to the public restrooms near the waiting area, pushed open the men's room door. Empty. I returned to the nurse's station. Did anyone see a middle-aged man, light blue shirt, walking through the ER? Marcus shook his head. Been quiet. No one's come through. What about the side exit? The ER had an exit that led to the ambulance bay, used by EMS and staff. It was secured with a badge reader. An alarm would sound if someone pushed through without scanning their badge. I walked to the exit, checked the door. It was locked from the inside. No alarm had triggered. The badge reader showed the last access was at 2:15 a.m. Marcus, returning from a smoke break. I returned to the nurse's station, my heart pounding. This didn't make sense. People don't just vanish. He would have had to walk past Jamie at the nurse's station. He would have had to go through a locked door, pull up the security cameras. I said, Jamie raised her eyebrows. You serious? Yes, please. She logged into the security system. The hospital had cameras throughout the ER, hallways, waiting room, ambulance bay, not in patient rooms for privacy reasons, but at every entrance and exit. She pulled up the feed for the main hallway leading to the observation bay. Scrubbed back to 2:47 a.m., the time I'd noted when the patient first appeared. The camera showed the hallway. Empty. The timestamp ticked forward. 2:47 a.m., 2:48 a.m., 2:49 a.m. No one entered. Try the waiting room. I said. She switched feeds. The waiting room had been empty since 2:30 a.m., when the last patient had been discharged. Ambulance bay. No one. This is crazy, Jamie muttered. She scrubbed forward through the timeline. 2:50 a.m., 3 a.m., 3:10 a.m., the present moment. No one left. I don't understand, I said. I was talking to him. He was there. Jamie looked at me with concern. Hey, you've been on nights for a week straight. Micro-sleeps can cause vivid hallucinations. It happens. You might have... I didn't hallucinate him, I said sharply. I took his vitals. I ran an ECG. Okay, she said gently. Okay, maybe he slipped out when we weren't looking. Maybe the cameras have a blind spot. I printed an ECG strip, I said. I reached into my pocket and pulled out the folded papers, unfolded them on the desk. The first strip, the one with the wrong timestamp, was blank. Just a header with a hospital logo, patient information fields empty, and the grid lines for the ECG tracing. No waveform, no rhythm, nothing, just blank paper. The second strip showed a normal sinus rhythm. Patient name field, empty, date, October 19th, 2024. I stared at it, my hands trembling. You okay? Jamie asked. I didn't answer. I folded the papers and put them back in my pocket. I walked back to the observation bay. Slowly this time. The hallway seemed longer than before. The fluorescent lights buzzed louder. I stood at the entrance to observation bay 2, looking at the empty bed. Everything was exactly as housekeeping would have left it. Clean sheets, empty bedside table, monitor off. Then I heard it, a faint beep. I froze. Beep. It was coming from the cardiac monitor. I stepped closer. The monitor was off. No power light, no illuminated screen, the power button not engaged. But the speaker emitted a single, soft beep, then another. Beep, beep, rhythmic, steady. I counted. 52 beats per minute. I reached for the power button, pressed it. The screen stayed dark. No response. The beeping continued. Beep, beep. I followed the power cord. It was unplugged from the wall. The monitor had no power source. Beep, beep. I backed away from the bed, my breath coming faster. This wasn't possible. Monitors don't run without power. They don't emit sounds when they're off. This violated every principle of basic electronics. I left the observation bay and returned to the nurse's station. Jamie, I said, can you come with me? She followed me back to observation bay 2. We stood at the entrance. The bay was silent. What am I listening for? She asked. The monitor, it was beeping. She looked at the monitor, walked over to it, pressed the power button. Nothing happened. It's off, she said. I know, but it was beeping a minute ago. She looked at me again with that same concerned expression. Maybe you heard a monitor from another room. I shook my head. It was this one. I'm sure of it. Look, she said carefully, why don't you take a break? Get some coffee. Sit down for 15 minutes. You've been running all shift. I wanted to argue, but I also knew how this looked. Medical student, sleep-deprived, claiming to see patients who don't exist, hearing sounds from unpowered equipment. Yeah, I said, maybe you're right. But I didn't take a break. I went to find Dr. Reyes. I found Dr. Reyes back in the physician workroom. She was on the phone with radiology, discussing a patient's CT results. When she hung up, I closed the door behind me. Dr. Reyes, I need to tell you something. She turned to face me. What's going on? I told her everything. The patient walking into the observation bay, the vitals, the ECG with the wrong timestamp, the registration system failing, the empty bed, the security footage showing no one entering or leaving, the monitor beeping without power. She listened without interrupting. When I finished, she was quiet for a long moment. You've been on nights for 2 weeks, she finally said. You're exhausted. Micro-sleeps can cause vivid, convincing experiences that feel completely real. Visual hallucinations, auditory hallucinations, false memories. It's well documented in sleep-deprived medical personnel. I know what microsleeps feel like. I said, this was different. I believe that you believe that, she said not unkindly. But the evidence suggests otherwise. No security footage. No patient record. No one else saw him. I have the ECG strips, I said. I pulled them from my pocket again, unfolded them on the desk. She looked at them. The blank strip with the header. The second strip with the normal rhythm and no patient name. These could be from any patient, she said gently. Or they could be test prints from when someone was checking the machine. The timestamp, I said. The first one said 2021. She looked at the blank strip. There's no timestamp on this one. I stared at it. She was right. The blank strip had no date printed on it at all. I saw it. I insisted. It said October 19, 2021. Dr. Reyes put a hand on my shoulder. Listen to me. You're a good student. You've done excellent work this rotation. But you're running on empty. When we're sleep deprived, our brains fill in gaps. We see patterns that aren't there. We remember things that didn't happen. It's not a weakness. It's just physiology. So you think I imagined it. I think you need to go home, she said firmly. Get some real sleep. Come back tomorrow night, and we'll talk about what happened. All right, I wanted to argue. I wanted to show her proof. But I had no proof. Just my own memory and 2 ambiguous ECG strips. All right, I said quietly. Good. Go home. That's an order. I didn't go home. I went to medical records. The hospital had been part of the same health system since the 1960s. Medical records for patients dating back decades were stored in the basement, first on paper, then on microfilm, now mostly digitized but with paper archives still maintained for legal purposes. I took the elevator down to B2, the basement level. The doors opened to a dimly lit corridor that smelled of old paper and air conditioning. I followed signs of medical records and archives. A clerk sat at a desk behind a glass partition, reading a paperback novel. She looked up when I approached. Help you? She asked. I need to access archived patient files, I said. I'm a medical student. It's for a case review. You need an authorization form from your attending. It's urgent. Patient care issue. She sighed. Name. Daniel Cormier. Selar Maillard. She typed into her computer. Birth date? March 8th, 1976. She searched. Waited. I'm not seeing anything in the active system. When was he treated? I'm not sure. Sometime in the past few years. Maybe 2021. If it's that recent, it should be in the system. Are you sure about the name? Yes. She tried alternate spellings. Search broader parameters. Nothing's coming up. Maybe he was treated at a different facility. No. He said he was here. Can I access the paper archives? She hesitated. Technically, I need approval for that. Please, I said. It's important. She studied me for a moment, then shrugged. All right, but if anyone asks, I didn't let you back there. She buzzed me through a security door into the archives. Rows of filing cabinets and boxes stretched into dimness, organized by year and alphabetically by last name. The air was cool and stale. Deceased patients are in the back section, she called after me, marked with red labels. I walked through the maze of records, following the red labels, found the section for 2021, started pulling boxes. It took me 40 minutes, but I found it, a thin file folder. Red label, Cormier Daniel. My hands were shaking as I opened it. Inside, intake forms, physician notes, lab results, and a death certificate. Cormier Daniel, DOB, March 8, 1976. Admitted to R, October 19, 2021, 2:51 a.m. Chief complaint, chest discomfort, dizziness, shortness of breath. Initial vitals, heart rate, 54 BPM blood pressure, 102/64 O2 saturation, 88% temperature, 96.8 degrees Fahrenheit, hypothermic. The intake note, handwritten by a medical student, not me, someone who'd rotated through 3 years earlier. Patient walked into R, unaccompanied, at approximately 2:50 a.m. Alert and oriented X3, presenting with vague symptoms consistent with possible acute coronary syndrome. Place in observation bay 2 for monitoring and workup. Patient unable to provide insurance information or emergency contact. Stated he has no family. Seemed uncomfortable providing personal details. ECG ordered. I flipped to the next page. A nursing note, timestamp 3:14 a.m. Went to check on patient in OBS Bay 2. Found patient unresponsive, no pulse, no respiratory effort. Code Blue called. Then the code documentation. Code Blue initiated 3:14 a.m. Patient in asystole. CPR started. Advanced airway placed. Epinephrine administered X4. No return of spontaneous circulation. Time of death called at 3:26 a.m. by Dr. Patricia Mills, attending physician. Cause of death, sudden cardiac arrest, etiology undetermined. Final note from Dr. Mills. Patient experienced unexpected cardiac arrest approximately 20 minutes after initial presentation. Despite aggressive resuscitation efforts following ACLS protocol, no ROSC achieved. Patient never provided complete identifying information. Hospital registration incomplete at time of death. Social services unable to locate next of kin. No SSN on file. State database search yielded no matches. Identity confirmed only by physical description and self-reported name. Body remains unclaimed. Will be transferred to county medical examiner for indigent burial. Attached to the file was a post-mortem photograph. Standard procedure for unidentified or unclaimed bodies. I looked at it. It was him. The same face. The same light blue shirt. The same calm, patient expression, even in death. I stood in the archives, holding the file, my heart pounding so hard I could feel in my throat. Daniel Cormier had walked into the ER 3 years ago on the same date, October 19th, at almost the same time, 2:51 a.m. He'd been placed in observation bay 2. He presented with the same symptoms. He had the same vital signs. And he died before anyone could properly register him in the system. No wristband. No complete medical record number. No next of kin notification. No funeral. Just a file in the archives with a red label. I made copies of the entire file on the ancient copy machine in the corner of the records room. The clerk didn't ask questions. I thanked her and left. I didn't go home. I went to the hospital library, a small room on the 3rd floor, mostly empty at this hour, with a few computers and stacks of old medical journals. I sat at a computer and opened the hospital's internal database. I searched for every patient who died in the ER in the past 10 years. It took 3 hours. I cross-referenced dates, times, locations, causes of death, and I found a pattern. October 19, 2018. A patient named Margaret Sullivan, age 63, walked into the ER at 2:53 a.m. complaining of abdominal pain. She was placed in observation bay 2. She died of a ruptured aortic aneurysm at 3:31 a.m. before registration was complete. Her body was claimed by family 3 days later, but the intake record was never finalized in the system. The chart had notes. Patient extremely anxious about providing personal information, seemed disoriented about recent events. October 19, 2015. A patient named James Roker, age 71, presented at 2:48 a.m. with symptoms of stroke. Placed in observation bay 2. Died at 3:19 a.m. Registration incomplete. Next of kin never located. Chart notes. Patient's responses to questions delayed and vague, as if uncertain of his own medical history. October 19, 2012. A patient named Andrea Chun, age 44, arrived at 2:55 a.m. with severe headache. Placed in observation bay 2. Died of cerebral hemorrhage at 3:22 a.m. Registration never completed. The social worker's note said, patient had no identification, no emergency contacts, no one to notify. Every 3 years. October 19th. Between 2:48 and 2:55 a.m. Observation Bay 2. Patients who walked in alone, gave minimal information, died within the hour, and left incomplete records. I sat back in a library chair, the fluorescent lights humming above me, and felt something cold settle into my chest. This wasn't random. This wasn't coincidence. This was something else entirely. I spent the next hour researching. Not medical journals. Those wouldn't help me here. I searched hospital history, local news archives, anything that might explain what I was seeing. I found it in a digitized newspaper article from October 1988. Local hospital fire claims 3 lives. The article described a fire in the emergency department of our hospital, then called Mercy General Hospital, before the merger that created the current health system. The fire started at approximately 2:30 a.m. on October 19, 1988, in the Observation Bay area. 3 patients died from smoke inhalation before they could be evacuated. The fire was ruled accidental, an electrical malfunction, and outdated medical equipment. The ER was rebuilt. New safety systems were installed. The hospital moved on. But the article included details about the 3 patients who died. One of them caught my attention. Daniel Cormier, age 36, admitted at 2:47 a.m. with chest pain. I felt the air leave my lungs. The same name, the same symptoms, the same admission time. But this was 1988, 36 years ago, which would make him, I did the math. If he was 36 in 1988, he would have been born in 1952, not 1976. The Daniel Cormier in the 2021 file was born in 1976. That would make him 12 years old in 1988. Different people. Same name. Or, I searched the 1988 hospital records, digitized but incomplete, found the intake log from that night. Daniel Cormier, DOB, March 8, 1952, not 1976. But the 2021 file said 1976. I pulled out the copies I'd made of the 2021 file, studied the intake form again. The handwriting was clear. DOB March 8, 1976. Someone had written it down wrong, or the patient had given the wrong year, or my hand was shaking. I forced myself to think logically. Option 1. 2 different Daniel Cormiers, both with the same birth date, month, and day, both presenting with chest pain in the same ER. Unlikely, but possible. Option 2. The same Daniel Cormier somehow appeared in 1988 at age 36, died in a fire, then appeared again in 2021 at age 45, and died of cardiac arrest. Impossible. Option 3. Something I couldn't explain with medicine or logic. I checked the other names I'd found. Margaret Sullivan, James Roker, Andrea Chun. Margaret Sullivan appeared in news archives. She'd been a school teacher who died in the 1988 fire, age 27 in 1988. James Roker, also in the fire, age 35 in 1988. Andrea Chun, also in the fire, age 8 in 1988. Every 3 years, on October 19th, around 3 a.m., patients with their names walked into the ER, presented with various complaints, and died in Observation Bay 2 before registration could be completed. But the ages didn't match. They were older, much older, than they should have been if they'd survived the fire. It was as if they were aging in death. As of every 3 years, they returned, a few years older, to repeat their final moments. I looked at the clock on the library computer. 5:47 a.m. The sun would rise soon. The night shift would end. I was supposed to go home. Instead, I went back to the ER. The department was quiet. Morning shift hadn't arrived yet. Dr. Reyes was in the physician workroom, finishing her charting. Jamie was restocking supplies. Marcus was helping transport a patient to the ICU. I walked to Observation Bay 2. The bed was still empty. The monitor was off. Everything looked normal. I stood at the entrance, waiting. I didn't know for what. Then I heard footsteps behind me. I turned. Daniel Cormier stood in the hallway. Same face, same light blue shirt, same calm expression. "I'm still not feeling well," he said quietly. My heart was pounding. My rational mind was screaming at me that this wasn't possible, that I was hallucinating, that sleep deprivation had finally broken something in my brain. But I could see him. I could hear him. And when I reached out against every instinct and touched his arm, I could feel the cold of his skin. "Mr. Cormier," I said, my voice barely steady. "What year is it?" He looked at me, and for the first time, I saw confusion in his eyes. I'm not sure," he said. "What's the last thing you remember?" He was silent for a long moment. "I came here," he said slowly. "I was having chest pain. They put me in a room. And then what?" "I don't remember." He looked around the hallway, as if seeing it for the first time. "Is this the same hospital?" "Yes." "It looks different. Cleaner. More modern." "Mr. Cormier, what year do you think it is?" He hesitated. 1988. I felt something cold wash over me. "It's 2024. He stared at me. "That's not possible." "You died," I said. "In 1988. There was a fire. You died in this observation bay." He shook his head slowly. "No, I just got here. And then, as I watched, his form began to flicker, not like a movie special effect, but like a television signal going in and out. He was there, then translucent, then there again. "I don't understand," he said, his voice fading. "I don't." "You're not alive," I said, "but you're not gone either. You're stuck, repeating the same moment." He looked down at his hands. They were fading, becoming transparent. "Help me," he whispered. "Please." "I don't know how," I said. "I don't know what to do." "Tell someone I was here," he said. "Put me in the record. Make me real." And then he was gone. Not gradually. Just gone, like a light switching off. I stood in the empty hallway, breathing hard, and I knew what I had to do. I went back to the nurse's station and logged into the Epic system. I created a new patient record, Daniel Cormier. DOB, March 8, 1952. The system accepted it this time. Generated a medical record number. I documented everything: arrival time, symptoms, vital signs, ECG findings. I noted his death in 1988. I attached the scan files from the archives. Then I did the same for Margaret Sullivan, James Roker, Andrea Chun. I documented all of them. I made sure their records were complete. I made sure they existed in the system. I don't know if it helped. I don't know if they found peace, or they're still trapped, or if any of this even matters in whatever reality they inhabit. But I documented it. I made it real. I gave them what they didn't have in life: a complete medical record. Dr. Reyes found me at the workstation at 6:30 a.m., staring at the computer screen. "I thought I told you to go home," she said. "I needed to finish something." She looked at the screen at the patient records I created. "What is this?" "Patients who were never properly documented," I said. "I'm closing their charts." She was quiet for a moment. "These are from 1988. "Yes." "Why are you documenting patients from 36 years ago?" I looked at her. "Because they deserve to be in the system. Because medicine is built on records. And when we fail to document someone, it's like they never existed." She studied my face. I don't know what she saw there. Conviction, exhaustion, maybe something else. "Go home," she said finally. "Get some sleep. We'll talk about this later." I logged out and gathered my things. As I walked toward the exit, I passed observation bay 2-1 last time. The monitor was on, not powered on. There was still no cord and outlet, but the screen glowed softly, showing a steady rhythm. 52 beats per minute. and then slowly it faded to black. I graduated 3 months later, top of my class, matched into an internal medicine residency at a different hospital in a different city. I never told anyone the full story. Dr. Reyes wrote me an excellent recommendation letter. If she suspected something had broken in me that night, she never said. But I still think about it. I think about Daniel Cormier and Margaret Sullivan and all the others. I think about the patients who slip through the cracks of our systems, who die before we can register them, who become ghosts in the bureaucracy of modern medicine. I've done research. I've learned that there's a term for them: statistical ghosts. Patients who exist in fragments, a blood sample here, a radiology order there, but no complete record, no proof they were ever alive. I wonder how many of them are still out there, trapped in the spaces between documentation and reality, waiting for someone to acknowledge them. I keep a notebook now. Every patient I see, I document meticulously. I make sure their records are complete. I make sure they exist. Because I learned something that night that they never taught me in medical school. The worst thing that can happen to a person isn't death. It's being forgotten, erased, never having existed in the first place. And sometimes the dead come back, not for revenge, not for closure, but for something simpler: to be seen, to be documented, to be real. I received an email 6 months after I left that hospital. It was from the medical records department. They'd found an error in the system. Patient files from 1988 that had been corrupted during a database migration in the early 2000s. The files of the fire victims were among them. They thanked me for reconstructing the records. They said it helped them complete an audit. They had no idea what I'd actually seen. But I know. And sometimes late at night, when I'm working a shift in my new hospital, I'll pass an empty room and hear it. Beep, beep, a monitor that shouldn't be on, a patient who shouldn't exist. And I'll stop and I'll document it, and I'll make sure they're in the system, because that's what they need. That's all any of us need, really: to be seen, to be recorded, to matter, even after we're gone. Author's note: this account has been documented in accordance with hospital protocols. All patient names have been changed. The events described occurred during my final year of medical school. I have no explanation for what I experienced. I only know that it happened, that I documented it, and that the documentation seemed to matter. Because sometimes the only thing standing between life and erasure is a few lines in a medical record. And sometimes the dead are waiting for you to write those lines.